So this will be available to you all for later, as well as your colleagues.
Exactly. I know we have several people interested who couldn't attend live today. I'm delighted to welcome Dr. Travis Osborne here to host this training on working with obsessive-compulsive disorder. We were just chatting a little before starting this that there's very little training for OCD, both in graduate programs and then what people tend to access afterwards. I know I've never received a direct formal training on OCD. So I'm so excited to be learning alongside you all today. And if you this training is eligible for 1.5 CEUs for free. So please just email Alyssa to check in on that, and she'll send you a form that you can fill out. With that, I'll turn it over to you, Travis.
Great. Thanks, Marcus. Welcome, everybody. Thanks for having me here today. My name is Travis Osborne. I'm a clinical psychologist. I work at the Evidence-Based Treatment Centers of Seattle, which is in downtown Seattle. And we're a specialty clinic that focuses on treatment of anxiety conditions, eating disorders, and DBT. And I head up our adult anxiety and OCD program. And I've been working with anxiety and OCD for probably about 17 or 18 years. That number gets bigger and bigger all the time as I get older. So today we're going to talk about evidence-based treatment of OCD. So I'm gonna go ahead and share my screen here to get this kicked off. Everybody see that okay? Great, okay. So let's talk real quickly about our learning objectives for the day. These are a few things we'll do. We're going to do way more than this, but we're definitely going to talk about the role of the brain in OCD symptoms and the research kind of related to that. I'm going to talk specifically today about the cognitive behavioral model of OCD, as that kind of leads to the main treatment that we're going to talk about, which is the components of exposure and response prevention treatment for OCD. One of the other things I'll say at the outset is exposure and response prevention is also the primary treatment for all anxiety disorders. So the principles or the components of what we talk about today with regard to treatment can be used for other anxiety conditions too. So things like social anxiety or phobias or panic disorder or things like that. So this will definitely have an OCD focus, but even if you don't treat folks with OCD, but you have clients with other anxiety conditions, you might think about how some of the principles we'll talk about today might fit for them too. And then I'll try to monitor too in case other folks join, let folks come in as they go. So just let's start with kind of a real high-level review of OCD. So the DSM-5, let me let somebody in here real quick and then I will proceed. The DSM-5 criteria for OCD shifted things a little bit. So prior to DSM-5, OCD was considered an anxiety disorder. So it was under the anxiety disorder classification. And in DSM-5, there was a big reorganization of many parts of the DSM. And OCD was moved out of the anxiety disorders into a new section called obsessive-compulsive and related disorders that now includes OCD, hoarding disorder, body dysmorphic disorder, and body-focused repetitive behaviors, which includes hair pulling and skin picking. So there was kind of a recognition that OCD was actually a little bit different than some of the other anxiety disorders. And we'll talk about some of those reasons today. And so this new kind of category was formed. The actual criteria for OCD didn't change all that much, so they're still pretty similar. So the first criteria we have is that folks have to meet criteria for obsessions. And so those are recurrent, persistent thoughts, urges, or images that the individual experiences as intrusive or unwanted. So this is very different from thoughts that somebody is thinking about on purpose. These are thoughts that by nature are intrusive or unwanted. And for most folks, is causing some kind of marked anxiety or some other kind of marked distress. And the individual attempts to ignore or suppress or sort of push away these thoughts, urges, and images in a way to neutralize them or to neutralize them with some other thought or action. So we have this dynamic where people are having these really intense and unwanted thoughts and experiences, and there's an attempt to kind of push back or get rid of those. For compulsions, what we have is repetitive behaviors or mental acts, and the mental acts is important because oftentimes when we think of OCD, we think of behavioral rituals that we can see, things like washing of hands or checking of things or things like that. But it's also important to know that lots of people can have rituals that are actually happening in their minds that you can't see from the outside. and that folks feel really driven to perform these rituals in response to the obsessive thoughts that they have or in response to rules that they feel they need to follow. And the idea here is that these compulsions are intended to help prevent or reduce the anxiety or distress that the individual is experiencing, or to prevent some of the feared outcomes they have that are related to the fears that they are experiencing. But often these behaviors are not connected in kind of a realistic way with the concerns that they're designed to prevent, or they're excessive in some ways. So if we take an example like hand washing, if somebody has excessive fears about germs or disease, certainly washing your hands makes sense as a way to mitigate that fear. But the level of hand washing that these folks are engaging in is so excessive with regard to what would actually be needed to take care of that problem that it becomes problematic for the individual. So folks need to have obsessions, compulsions, or both. I'll just give you the punchline, which is everybody has both. Nobody has one or the other. There's always both. We can talk about times when people think that they maybe don't have both, but they always have both. The symptoms need to be time consuming. So this has to be more than kind of a, couple minutes a day or sort of like a idiosyncratic behavior that the person might have. So the cutoff is usually it takes at least up to an hour or more a day of engaging in the thinking and the rituals. And it does need to cause some kind of, clinical impairment or distress, just as with all disorders. Symptoms need to not be attributable to another mental health condition or other condition, as with other disorders as well. And then this is pretty unique. There's actually only a handful of disorders in all of DSM that you actually have to specify the individual's level of insight. And the reason that's important is because the fact that that's included is a clue to us that this is an issue for a subset of folks. So there are many people with OCD that have good insight, so they can recognize I'm having these thoughts, I'm doing these behaviors, they feel really real and true to me in the moment, but if I step back, I can recognize this probably is not real, and I see that other people are not, behaving this way. But I still feel really compelled to do it. And then there are folks with poor insight where some of the time maybe they do have that awareness, but some of the time they really don't. Like the thoughts feel very true to them, they feel very real to them. And then there are folks that's all they experience. It's like these thoughts are fully true, my fears are very real, and they have very little awareness that perhaps this is a mental health condition that is occurring. And then also specify if folks have a history of tic disorders. We're not going to get into that today, but there's a little bit of an emerging literature that when people have both tics and OCD, it might present a little bit differently. It's not necessarily it's not the most common presentation, but if you do see that, there's a way to specify that as well. So those are the criteria that we're thinking about when we're talking about OCD. So in terms of what this looks like, about 1.2% of the US population will develop OCD in any year-long period. So it's about 4 million people at any given time. So very common. Typical mean age of onset is just under 20, but a full quarter of folks develop OCD before age 14. So this is very often something that shows up in childhood or adolescence. And we see kids starting to engage in lots of ritualized behaviors. Very unusual for this to start later in life. So almost unheard of to start, at 30s or later. There's always some kind of history or seeds of the behaviors earlier than that. By adulthood, the rates of OCD are equal. It's pretty much 50-50 between men and women, which is different than a lot of other disorders where we see kind of gender differences. However, males have an earlier age of onset. So in childhood, you'll see more boys with girls with OCD, but by adulthood, the rates even out. And the course does tend to be pretty chronic. So this is not a disorder that tends to remit or go away on its own if it's untreated. It can wax and wane. The onset can be pretty gradual, but sometimes can start like very abruptly. But like I said, most people, the symptoms can kind of come and go over time, but they don't tend to just go away on their own, which is why treatment is so important. In terms of comorbidities are definitely the norm. So a good 75% of folks are going to have some other anxiety disorder in addition to OCD during the course of their lifetime. And another, almost 2/3 are going to have a mood disorder, with the bulk of those being major depression. About a third have a tic disorder, hence the tic specifier that we just talked about. And then a little less than a third might also have OCPD, which is a personality disorder, which is pretty different. If we have time, we can talk about the differences later, but it's just good to know about. But good to know that for the majority of folks, there's going to be at least another anxiety disorder, possibly a mood disorder, in the mix over the course of their lifetime. Very common. So what do people actually obsess about? So I'm going to go over the most common obsessions and compulsions that we see clinically and in the literature. But one thing that's very important to note is OCD can literally be about anything. It is literally only bound by the human imagination. So you might have a patient that clearly looks like they have OCD, but you're like, their thoughts don't seem to fit any of these categories. It's important to know that these categories are just the most common ones, but you can have very idiosyncratic OCD presentations. One of the most common things most of us think about with OCD is contamination concerns. So these are fears about becoming contaminated or spreading contaminants to others. But within contamination, you can have a wide range of what that's about. So for a lot of people, it's about germs and illness. For other people, it's just about things that feel dirty. So things like body fluids, different kinds of waste, cleaners, poisons, environmental toxins, any of those things can be the focus of contamination concerns. Harm obsessions are also very common. These are thoughts about hurting yourself or others, either intentionally or unintentionally. Sometimes those are verbal thoughts, but frequently they're actually images or kind of movies kind of playing in people's mind about harm coming to self or others. Sexual obsessions are also very uncommon or very common. These are unwanted sexual thoughts that feel really ego dystonic to the person. Common things are thoughts about what if I'm a pedophile, thoughts about having sex with kids or animals or family members, things that to the individual feel taboo or inappropriate in some way, and they don't want to be thinking them. Scrupulosity or moral or religious obsessions, also pretty common. For people who are actually religious, these could be thoughts or feelings that they feel are sinful or blasphemous. People can doubt their level of faith or whether God exists, things like that. For folks who might not be religious, this can show up in a more secular way. So it could be concerns about what's right or wrong, whether I have done something that's wrong in some way or violated some rules or kind of social norms, things like that. Just right or perfectionistic obsessions, needing things to be in a certain place or order. But that could also look like, did I speak correctly? Did I understand something correctly? Did I read something correctly? Did I write something correctly? So it's not always about kind of arranging things or symmetry or things like that, but it can also be like, have I done things kind of perfectly? And then some folks, and this is not terribly common, but some folks can just have what we call neutral obsessions, which are just sounds, words, images, pieces of music that just repeat in their heads for weeks or months or years at a time, that it's very irritating and frustrating and they don't want to be thinking about it, but it doesn't necessarily have like a really strong emotional valence or fear attached to it. In terms of common rituals that people engage in, not surprisingly, decontamination compulsions are very common. It's things like washing, showering, hand washing, cleaning, disinfecting, throwing things away that feel contaminated or dirty. Checking compulsions are also very common. So repeatedly checking either in real life or in one's memory, like reviewing situations from their life. Things like locks, doors, electrical appliances, outlets, light switches, car settings, homework, checking one's own body. Checking can really be check anything, it turns out. So checking can be about just about anything. Just right compulsions or perfectionistic compulsions could be arranging things in a certain way or in a symmetrical way. Could be doing or repeating activities until you get a feeling that it's just right in your body. Could be confessing things to other people, rereading, rewriting. You see that a lot with kids in school. Homework can take hours and hours and hours because they're having to reread the same material to make sure they understood it perfectly, or rewrite the same material over and over again until it's done perfectly. It can really wreak havoc with school performance. Lots of different kinds of movement compulsions, so having to move in specific ways. Sometimes it's excessively slowly, sometimes it's in a certain pattern, having to touch certain things or walk in certain ways. Obviously, you can imagine moving about the world can be really challenging when that's the case. And then for some people, things that are related to numbers, so doing things a particular number of times or counting things, and certain numbers being sort of good or bad can kind of be part of the process. So what you're already starting to see is OCD can be very complicated. There can be many different ways it can show up. And across patients, depending on which of these symptoms somebody has, it can also look very different. You could have two people with OCD that look nothing alike. which is both what makes OCD challenging to treat, but also very interesting to treat because there's a lot of variety in terms of kind of what folks are experiencing. If we look at a really large sample, close to 100, sorry, not 100, 1,000 patients treated at Butler Hospital at Brown for OCD, this is sort of the breakdown of their symptoms. So on the left, what you see is about half had contamination, close to 40% doubting obsession. So did I do X? Like, did I turn off the light? Did I turn off the car? Did I, that kind of thing. About a third having obsessions about their body in some way, so somatic concerns. Almost a third having harm-related obsessions. About a quarter having sexual thoughts, like we talked about. About 10% with those religious or scrupulosity thoughts. What you'll see is that adds up to more than 100%. So that means most people with OCD actually have more than one type of obsession. It's not uncommon to have multiple subtypes of OCD at one time. And same thing on the right. So if we look at common compulsions, those also add up to more than 100%, meaning most people have more than one type of compulsions that they're gauging in too. So these symptom presentations are often very complex. In terms of what we know about where OCD, how it develops, so OCD is definitely considered a neurobehavioral disorder. There's a lot of research on the role of the brain in OCD. There's a decent amount of genetic research that's been done around OCD. And what that genetic research in particular seems to point to is there's probably not like a single gene for OCD specifically, but there's probably a multiple of genes that interact together where people inherit a genetic vulnerability to have kind of OCD behaviors. And without that vulnerability, it's a lot less likely that someone would develop OCD. And we see the same thing with lots of other conditions. There's lots of folks who have a genetic vulnerability to things like heart disease or high cholesterol that are just much more likely to develop those problems than somebody who doesn't. And we think the same is probably true for something like OCD. Part of what tells us that is the rate of OCD in first-degree relatives with OCD is twice that of those without OCD. So we're seeing this familial, really high familial increase. And we also see a much higher occurrence of OCD in identical versus fraternal twins. So folks who share more genetic material, much more likely to have the disorder if the other person does. We also know there's a role for serotonin in OCD, as we know there are for many mental health conditions. And it's not that OCD is related to not having enough serotonin in specific parts of the brain. It's probably more related to not having enough overall. So that I read that backwards. It's not that you just don't have enough serotonin. It's that there's not enough serotonin active in the parts of the brain that are related to OCD. And we are going to talk about those parts of the brain in just a minute. And then we have some great imaging studies, actually from the 90s, which are really unique data in mental health, where we actually have identified very specific parts of the brain that seem to function differently in folks with OCD than folks who don't have OCD. I'm going to walk through these brain structures in a minute because it can be really helpful to actually educate clients about the fact that this is the case. And what we call this kind of, there's a circuit in the brain that seems to be involved in OCD that we kind of just call the worry loop because the formal name is way too technical to give folks. And we kind of think this is where a lot of OCD symptoms kind of develop in the brain. And so what you can see here on the left are these three kind of main structures of the brain that we're going to talk about. The first is the orbital frontal cortex. This is the front part of the brain. This is kind of the most advanced part of the brain. Does many things, but one of the things that it does is help us detect when something is wrong. So it's kind of like our internal alarm system, that there's some sort of problem or issue that needs to be dealt with. So this goes off in all sorts of ways, as we move through our days as a way to help us navigate problems and keep us safe. And if that alarm is triggered, it sends a message to the striatum that there's some sort of problem here that we need to solve. But in OCD, it's being triggered by lots of thoughts and feelings that don't seem to bother other people, right? So if somebody with contamination OCD touches a surface in a public building, their brain starts to have thoughts that perhaps there's, there's COVID on that counter or HIV on that counter or some other, really serious illness on that counter. Whereas lots of folks with OCD probably don't even give a second thought to the fact that they just put their hands on the counter at the store as they were checking out or something like that. So the alarm system is much more sensitive and is being triggered by all kinds of things that other people are not being impacted by. So when that happens, it sends a message to the striatum, whose job is to act as a filter or a brake pedal to help determine which of these alarms are actually valid that we need to respond to and which are kind of like spam or junk mail that like actually it turns out we don't really need to respond to. Because if you think about how much information our brains are taking in throughout any given day, there's tons of things that we might at first think is a problem or an issue, but we get a little bit more information and we realize, actually, I don't need to worry about that. So like you might be sitting at home and suddenly hear a crash in the room sort of next to you. And you could have the thought, oh, what if somebody is trying to break into my house? But then you remember you have a cat and the cat likes to knock over the plant in the next room, and you realize, actually, this is not an issue that I need to deal with right now. Or then you hear the cat, scamper away. But we all have these kind of false alarms that happen. And this part of our brain is to help us figure out what's real and what's not real in terms of threat or our safety. So what happens with OCD is that this kind of filter does not work quite right. And it allows messages that are not kind of based in fact to kind of get sent to the next part of the brain, who then starts to respond as if there is a real threat that needs to be taken care of. So I think about it as a broken spam filter. All of that kind of alarming spam that you get with all these like dire messages about what's happening, it's like it's all going to your inbox. And so it feels like, oh, these are all messages that I'm actually supposed to be responding to. These are kind of real threats. And so when that message gets through, it's sent to this part of the brain called the thalamus, which basically functions as a relay station who's designed to recruit all the other parts of the brain and the body that are needed to solve that particular problem. And this happens for us every day. This part of the brain helps us respond to all kinds of things. And then when that happens, it's supposed to send a signal back to the orbital frontal cortex that we solved the problem. Like the problem's over, we can turn off the alarm now. Well, what happens in OCD is so many messages are getting through to the thalamus that are being treated as if they are real. The thalamus gets pretty overwhelmed. This part of the brain, I kind of think about it as kind of like overheating. It's not literal overheating, but I think of it as like it's kind of overheating. There's too many messages. It's working really hard to do all these rituals and all of these things to kind of keep the person safe. And then it's trying to send these messages back to the orbital frontal cortex that we've solved the problem, but the alarm doesn't get turned off. It's still going. And examples of that you can see is when like people are checking a light switch like 15 times. It really only takes one time of checking the light switch to know that the light is off, right? The alarm should go off at that point, but it doesn't go off. The alarm stays on even though we just solved the problem, and the brain feels like, I need to do it again. Okay, the alarm is still on. I need to do it again. Okay, the alarm is still on. I need to do it again. And that's where you can see these really lengthy periods of people just stuck in behavioral rituals that they can't get out of. So this network of structures in the brain, we'll talk about, I think, in a little bit, but there's actually some great data that we have that treatment actually changes the way this brain circuitry works. We have fMRI data that shows that I'll talk with you about in a little bit. And it's just really helpful information to share with clients, that there's actual reason why you are feeling the way that you're feeling, why you are feeling so stuck in the behaviors that you're doing. There's something real that's happening in your brain that we know can shift, with the treatments that are available to you. And so it's just it's useful to understand the role of the brain and how this works. So the brain and biology is an important piece of the puzzle, but what we also know is that learning plays a critical role in what happens with OCD over time. And some of you may be familiar with behavioral psychology, behavioral principles. Some of you may be less familiar with that. So just kind of a quick note about this. So we have something called negative reinforcement, which essentially is when folks with OCD feel anxious and they engage in either avoiding altogether or doing some kind of rituals to make themselves feel better, they of course get this temporary reduction in discomfort, as we all would when we get away from something that's making us uncomfortable. Unfortunately, what that temporary reduction in discomfort does is it strengthens the likelihood that the next time you're feeling anxiety about that same trigger, you're going to do the same thing. You're either going to avoid again or you're going to do rituals again, which is where we start to see these patterns get really reinforced over time, where folks are doing more and more and more rituals, even though it's only leading to these very temporary feelings and discomfort. And then the other thing that happens is we're always doing avoidance or rituals in response to being distressed. We never actually get the chance to learn that actually I'm safe even if I don't do these things. Like I'm going to be okay and my anxiety is going to come down even if I don't engage in all this avoidance and ritualized behavior. And so we see this kind of maintenance of this cycle over time. And what that looks like, and I will draw this out for clients when they come in for treatment, is there's some sort of trigger for folks' OCD, which we'll walk through what some examples of those might be in a minute. Folks start having obsessive thoughts about that trigger and then get very anxious when they have those thoughts. When they're anxious, they start to engage in some sort of compulsion or avoidance, and so they get this temporary relief. And so it might break them out of that cycle, but the problem is the next time there's a trigger, we're right back into this same cycle. And so you get these really intense cyclical patterns that folks get stuck in that tend to get longer, more kind of involved, and kind of bigger over time. So let's just give some examples of what that might look like for different types of OCD. So let's say somebody had contamination OCD and a common fear is contracting HIV. One thing I'll say about this too, the diseases that folks worry about contracting change as the world changes. So when things like SARS or COVID or Ebola, when there's outbreaks of different things in the world, you see OCD, folks with OCD shift what's salient, to the things that are most salient at the time. HIV is certainly one that a lot of people do still have concerns about. Although I will say, interestingly, in the 20 years I've been in practice, this has shifted now that we actually have treatments, for HIV, that the meaning of having HIV has shifted a bit. And so you see probably maybe less of these concerns than you might have 20 or 30 years ago when we didn't have treatment for HIV, as an example. So a trigger could be having to leave a public restroom and having to touch the bathroom door handle on the way out. The thought could be, I could get HIV or some other illness if I touch that. If you believe that that's true, of course, you're going to feel anxious. A compulsion might be, I'm not going to touch the handle. So I'm going to use my shoulder to get out of the door. I'm going to use a paper towel to get out of the door. Or I'm going to go excessively wash my hands in some other way if I have to touch the door, or use hand sanitizer or something like that. And so you get this short-term decrease in your fear about contracting that illness. If we take another example, another common one, a fear of harming others is a fear of hitting someone with your car. So if someone hits a bump in the road or there's a pothole, the thought might be, oh, I just might have killed somebody or hit somebody with my car. It's a really common OCD fear. And obviously, if you think you just hit someone with your car, you're going to feel very anxious. And so compulsions are often like drive around the block, circle back to where you were to see if somebody's lying in the road or on the side of the road, or if there seems to be a crowd of people, who are alarmed about something having happened. Some people might mentally retrace their steps or the events in their mind, or go home and look for news reports of was there a hit and run today? Was there some sort of accident today where somebody left the scene? And those things could lead to some short-term decreases in fear. If we take a scrupulosity example, somebody could be sitting in church or some kind of religious service and have what they feel is like a bad or blasphemous thought. And then they might have the obsessive thought, I've offended God and I'm going to hell. Obviously, if you believe that, you will feel fear. And so compulsions might be praying a certain number of times, confessing that thought to other people, either religious officials or other folks in your community. Could be seeking reassurance from others about whether they think we go to hell if we have, bad thoughts, things like that, all of which could lead again to these short-term decreases in anxiety. So what you're hopefully starting to see here is it kind of doesn't matter what the content of the thinking is or what the content of the ritual is. The pattern is the same, right, across all different types of OCD. There's some kind of trigger. The person has some kind of thought, either verbal or image, that makes them fearful, and then they do things to try to mitigate that fear, and then they get this temporary relief. But the next time it happens, the cycle starts kind of all over again. Any questions there, just to stop? I know I've already thrown a lot at you in 30 to 25 minutes, so let me pause. Are there any questions about the types of OCD, what the symptoms look like? We're going to talk a ton about assessment and treatment, but any questions so far?
No, it seems clear. I really like that brain triangle. That's helpful. Kind of a basic sense of understanding how
Yeah.
the signal pattern goes through.
Yeah, and I draw that on the board for all my clients. And I tell them I'm not a neurologist, so I'm not going to be able to give you the most detailed neurologic understanding of what's happening. But here's what's happening in your brain. And for most people, it's so both validating because they have this feeling of really being stuck, and kind of relieving that there's a reason why this is happening. Because the other thing that can happen with any mental health condition, including things like OCD, is from the outside, it could appear to loved ones or things like, why don't you just stop these behaviors, right? Like, can you just stop washing your hands? Like, it's not a problem. Like, inadvertently, or sometimes on purpose, people can be very invalidating or send the message that, like, this is something you're doing wrong that you could just stop doing at any point. And people understanding the brain basis of this problem really helps to kind of destigmatize that and help them understand, like, this is not something that I'm doing. Like, my brain has a predisposition to this problem. There are behaviors I can change to help break the pattern, but this is not something I created. Okay, so all good treatment starts with a
Um,
good, yeah,
Real quick, Travis, you
yeah,
might be getting into this, but one question I have is the assessment of like the mental checking with somebody and how that might be,
yeah.
um, I don't know, different or like how to assess how much time is being spent doing that. And if that's a feature of the OCD or if it's something else like anxiety or
Yeah, yeah.
PTSD even.
We are definitely going to talk about that. That
Okay,
is
cool.
coming soon. And then I'll stop there and see if I answer it adequately or not. Okay.
Okay, cool. Thank you.
You bet. Okay, so treatment's going to start with a really thorough
Oh,
assessment.
it looks like we have a couple questions.
Oh, yeah, yeah.
Amisha, you want to start us off?
Yeah, you may be going over this, but just wanting to know, like, how, if you're going to cover or maybe talk a little bit about, how it might affect other people, like loved ones that are living with someone with
Yeah.
OCD, and what, like, you just briefly talked about how, it's easy for somebody to say, oh, it's just stop
Yeah.
or something like that. But will you be talking, or is there somewhere that we could learn more about how other people who live with someone with OCD could be more nurturing, I guess,
We
to the
can
person
definitely
with
talk about
OCD?
that. Yeah, particularly when we get into what the treatment looks like, because
Okay.
oftentimes many families are greatly impacted by the OCD,
Right.
either because of how much anxiety and ritualizing is happening in the household, or that they have to actually participate in the ritualizing too.
Right.
Spouses, parents, so this can really take over like the whole house. And so when we get to the ERP treatment model, if there are folks that are really involved with the OCD, they have to be pretty heavily involved in the treatment because we need to
Mm,
help them slowly back out of kind of all the accommodating that they're doing of those behaviors or kind of participation in those behaviors. So I can definitely point
right.
out as we walk through ERP, like how families would be involved in that kind of unwinding process.
Okay. Wonderful. Thank you.
Yeah, you bet. And do we have one more hand?
Yeah, Amanda.
Yeah, hi. I was just really curious. You had mentioned that in diagnosing that there's this like specifier of adding level of insight. And
Yeah,
I find that so fascinating. I work with a lot of folks around disordered eating or eating disorders,
yeah,
and that is oftentimes a barrier, is like
yes,
their level of insight as
for
well.
sure.
And so I was curious if you have seen that level of insight change during treatment? Like, is
Yeah,
there
yeah.
correlation there for that?
Several things can help insight. The first one is medication. So medication treatment can kind of turn down the volume on some of these symptoms and actually create more insight into what's happening. So that can often be a critical part of the puzzle. The other thing is that sometimes being in treatment and kind of spending a fair amount of time in what I would call pre-treatment, like before we actually start trying to change anything, of building awareness through some of the things that I'm about to talk about with assessment can actually help some of those folks start to see that this is actually OCD, or at least get more on board with the idea that this might be OCD or some kind of anxiety condition before you can then sort of move on to treatment. So I will say more about that in just a minute.
Thank you so much.
Yeah. So at a basic, we want to make sure someone actually meets the DSM-5 criteria for DSM, for OCD, obviously. Then I'm going to talk about a specific symptom measure that's really helpful to use. And then we're going to talk about functional assessment of what this actually looks like in people's day-to-day lives. So in terms of the symptom measure, so the Yale-Brown Obsessive-Compulsive Scale, or the Y-BOX, some of you may have heard of, very widely used, probably the gold standard measure of OCD symptoms. It's the measure that's used in all the treatment trials for both medication and therapy. It's really easy to administer because it's only the symptom part of it's only 10 questions. It can be filled out in like 1 or 2 minutes, which is really nice if you're in practice. There's also a self-report version, so it's like really easy for people to fill out on their own. There's two parts. One is a symptom checklist that you don't score. It's just to help you gather information. And then the severity rating that's actually scored. So the symptom checklist is just a really long list of different kinds of obsessions and compulsions, kind of similar to the slides that I mentioned earlier about the different ways OCD can show up. It's great to use in an intake or in early stages of assessing OCD, where you can just go through and ask lots of questions about, are these thoughts or behaviors that the individual experiences? And most of the time, folks, particularly if they have thoughts about harm or sexual obsessions that they really don't want to be, experiencing, if you just say, like, tell me what you're thinking about, they're not going to volunteer. I'm thinking about having sex with children. No one's going to really volunteer that. But if you say, hey, one of the really common things that we see in OCD are unwanted sexual thoughts, and that can look like things like, worrying if you're a pedophile, or worrying about having thoughts with sex with kids or sex with family members. Like, is that ever anything that you've experienced? People are much more likely to endorse kind of an example that you normalize and say is common than just to kind of volunteer it on its own. It's really helpful kind of from an assessment standpoint. And then the actual severity measure has 5 items about obsessions and 5 items about compulsions. And it asks things about, like, how long are these symptoms taking up in your day? How much distress do they cause? How much does it interfere with your life? How hard are you trying to resist or kind of control the symptoms? Questions like that. And the measures a range of 0 to 40, with a cutoff usually of being 16 or higher is kind of a more reliable cutoff for folks that usually meet criteria for OCD. And then with kind of severity ranges here. And so you can Google the Y-box, you can get access to it really easily. Easy, quick to use with clients who you think might have OCD symptoms. So in terms of symptom measures, I definitely recommend that. But then what we're going to spend a lot of time in treatment doing is a functional assessment of, what does this actually look like for this person's, specific life? And we're going to start that process during the intake, but really this is going to happen over the first several treatment sessions, where we're gathering lots of information about what does OCD look like for you as you go about your day-to-day life. So essentially what we're looking at is a really careful examination of the factors that seem to precipitate the client's symptoms, and then talk about specific examples of how OCD is happening, in a given day, and how this fits together. And things that we're looking for, like, what are the triggers? So what set these episodes off? What are the obsessive fears that you're having? And then what are the compulsions or avoidance behaviors that you're doing? And then what emotions are you having during these episodes? And so the first couple weeks of treatment are this self-monitoring phase that we're hoping does a couple things. We want to provide this information about what this looks like in day-to-day life. We want to have the therapist and the client kind of starting to speak the same language as they talk about OCD. We want to orient people's attention to how their OCD shows up kind of in day-to-day life, and raise awareness of their symptoms and the patterns in their symptoms. And so to the question that was asked about insight, sometimes the act of tracking these episodes really helps people start to see, oh, I'm now starting to see this, like, repeated pattern of how these things show up for me, how they're consistently triggered, what I actually do in response to them. And sometimes the act of that can raise awareness, raise insight, but also kind of get people's buy-in that, oh, actually maybe this is OCD after all, which can be really helpful. A part of that monitoring is using a simple tool. It's called SUDS, or subjective units of distress, for how to kind of put a number to how intense your feelings are in any given moment. It's a commonly used tool when we treat anxiety. Typically we use a 1 to 10 or a 1 to 100 scale. I would encourage people to use 1 to 10. Folks with OCD can spend a lot of time, I'm not even joking here, this actually happened, determining whether their feelings are like an 85 or an 86, when that is not so important. So less options is usually better. So 0 to 10 can be more helpful. And the scale is specific to the individual. So it's not designed to compare across clients, but essentially it's just a quick way of communicating how distressing is this situation for you. 0 is I'm no distress, I feel totally fine. 10 is like the most distressed I've ever felt, with other anchors in between, as a quick way to rate how the person is feeling. And so what I would have folks do for the first couple weeks of treatment is fill out a log that looks something like this. It could be on paper, people could track it electronically, however they want to do. Like, what's the date and time? What was the situation that was happening? What was the obsessive thought or intrusive thought that you had? Did you do any compulsions, and how much time did it take up, and how distressed were you? So let's take an example of somebody who has sexual obsessions about kids. So let's say On Monday at 8:30, I was taking a walk in my neighborhood as parents were dropping off their kids at the school that's at the end of my block. So that'd be the situation or trigger. And the obsessive thought I had is, oh my God, there's kids around. Like, what if I'm attracted to one of them? Or what if I'm, what if I'm a pedophile? And then the compulsions that I had were, so the avoidance I did was I left immediately. I went back home. I turned right around. I got away from the kids. And I started reassuring myself that, I've never acted on these kind of thoughts before. Trying to check my body for any signs of arousal that I might have had while I was seeing the kids get out of the car, that kind of thing, to kind of reassure myself that I'm not a pedophile. And let's say that whole thing took 20 minutes and my SUDs were pretty high, like it was like an 8 because there was actual kids around. So that would be an example of like what somebody would fill out on this log. And then the next time they had an OCD episode, either about those thoughts or different thoughts, they would kind of record what the next episode looked like. So after a couple of weeks, what you start to see is the same kind of usual suspects showing up over and over and over again on people's logs. You'll start to see if somebody has sexual obsessions, you're starting to see repeated patterns of how this is being triggered in their life. If they have contamination concerns, you're starting to see the pattern of what tends to set those things off too. So this is a really kind of critical part of the process. So we'll have them do this for a couple of weeks. Clients can get pretty perfectionistic about these logs, which is not helpful. I did have a client try to log every single OCD symptom she had for a week, literally brought about 20 of these sheets of paper back to me. It's not what I need from her, and it was way too much work. So I've been careful ever since to let people know, like, we just need like a cross section of what are the typical kinds of things that you experience, not everything you experience, but just so I have a good sense of what this looks like. And then we're going to stop doing this when we feel like we have enough information to really kind of move on with the treatment. So in terms of treatments, at a high level, the gold standard treatments for OCD as of now are medications, namely the SSRI medications. And exposure and response prevention, or ERP, is considered the primary treatment for OCD at this point. We definitely recommend that folks try these treatments if they're willing before trying other types of treatment, just because we have a lot of data on them. But we also know that it's very common for people with OCD not to receive evidence-based care. As we talked about at the beginning, most of us don't have any training in treating OCD. I know I got zero training in the treatment of OCD in my graduate work. I didn't even learn this until I was done with postdoc. After I was done with formal training, I finally learned about OCD. So most folks don't get the right care because most of us aren't trained in the treatments. And so if we can point folks in that direction, it's really important. I know you all aren't prescribers, but it's important to kind of be aware of kind of the importance of medication. So just real quickly, one study that looked at collapsing data from 32 different medication clinical trials for OCD with about 3,500 patients found that medication helped about 2/3 of folks see pretty notable decreases in their symptoms compared to placebo, which was only 23%. So it's a huge gap. So that's telling us, the medication is definitely doing something. A separate study looked at what happens with different levels of dosing of medications with OCD. And one of the things we do know about OCD treatment is that we need to usually do higher doses of medication to be more helpful with OCD than things like depression or generalized anxiety or just kind of more other anxiety concerns. So oftentimes people might be on an SSRI, but they might be on a low dose, and chances are they're not actually going to get the most benefit from that. And a lot of prescribers don't know this data. So it's helpful if you know it and can kind of, encourage them to talk more. Obviously, higher doses of medication can also lead to higher side effects. So that's kind of a balancing effect that prescribers need to do there. But the idea is medication definitely helps. Higher doses are often needed. And then in terms of ERP has been around for close to 40 years now. It was developed in the 80s. And so a recent study came out in 2021, looked at 36 different randomized control trials of ERP with over 2,000 patients and found a pretty good effect size for the treatment. So the treatment works well when we compare where people's symptoms are before and after treatment. Those differences are bigger when we compare to things like what we call non-active control. So things we wouldn't expect to change OCD, like teaching relaxation strategies or just giving them education. we wouldn't expect those things to change OCD, and in fact, they don't tend to. And so we see a large effect when we compare to things like that. And then even when we compare ERP to medication, so when we do head-to-head with medication to ERP, we still see an advantage. It's small, but we still see an advantage for ERP even when we're comparing to medication. So we really have these two treatments that actually both work. And there's actually some data that when you combine medication and ERP, you can get even some better results too. So I won't belabor that much, but if any of you happen to treat kids, we also have parallel studies that show it's really effective for kids too. So this study looked at over 46 different studies with kids with OCD and found really large effect sizes from pre to post treatment on both OCD symptoms as well as for their functional impairments. So kids just got a lot better, a lot less impaired by doing ERP. And then we know with kids, and this gets a little bit to one of the questions that was asked, is parents are going to be heavily involved in this treatment because they're usually heavily involved with the OCD itself. And we know that treatments that do include parents more, we actually get better effects, which makes sense. And with kids, we also get some better effects when we add in some other things with them. So we do ERP, but we also teach them some strategies for talking back to their thoughts. And we put in things in place to help them prevent relapse, things like that. We get even better effects as well. But high level point here is we've got tons of data with adults, tons of data with kids, all showing that this is an effective way to approach treating OCD. I want to say a quick caveat about the nature of the data that we have. It's a really important study came out in 2010 that looked at the number of ethnic minority participants in randomized controlled trials for OCD between this 20-year period of time. And this is coming from the reality that much of science is conducted with, kind of majority culture folks. And interestingly, what they found is only about half of the trials even reported data on the ethnic breakdown of their samples, which is odd because most scientific studies actually do report that. Of the ones that did, so about 2,200 folks, this is what they found in terms of the ethnic breakdown of participants. So this very large database that we have about ERP is a heavily white database. And I think that's just important for us to keep in mind when we're working with folks from more diverse backgrounds. So we don't have a reason to believe that ERP won't work for them. We just don't have a lot of data that kind of helps us kind of say that more definitively because research has not done a great job of including more diverse communities. So it's an important kind of caveat and thing to note there. Okay, so as I mentioned, ERP was developed in the 80s by Edna Foa. Some of you may be familiar with her name. She's also the person who developed prolonged exposure therapy for PTSD. These were developed at the same time on the same set of principles. And so we had these two treatments kind of develop around the same time. And so it is an exposure-based treatment. So this is a form of exposure therapy, and it's based on the principles of extinction learning. So what we have in OCD are these triggers that lead to obsessive thoughts, and then these feelings of distress, and then people either avoid or do rituals to make themselves temporarily feel better. And so we really get this cycle that repeats itself over and over and over again, but really only gets this like momentary or temporary relief. So it's a lot of work for the individual, but it doesn't actually get them out of this cycle on a more permanent basis. It just gets them out on a very temporary basis. And so what we do with ERP is we're actually teaching people how to break out of this cycle more completely in a way that's going to change the symptom picture in a much more significant way. So we're going to do that with two components. The first is exposure, which involves directly confronting the triggers or obsessive thoughts that cause people distress instead of trying to avoid them or push them away. And we all know this, any kind of fear is conquered by facing it, right? So the more you do something that makes you feel uncomfortable, whether that's feeling anxious or fearful or just discomfort, the less fearful you tend to become of it over time. It's a simple concept that we all know, but it's hard to implement in practice when you're very fearful. But in order for that to work, the person with OCD really has to stop doing the things that are getting them this temporary relief. So they have to also stop doing the compulsions and avoidance behaviors. And that part of the treatment is the response prevention. So we're really trying to help people prevent doing those things that are kind of maintaining that system and learn that their anxiety and distress is going to come down on its own, as all anxiety and distress does, if they don't engage in those behaviors. And we really need both parts of this treatment to be effective. And I want to emphasize that because a lot of therapists who might start to do this will really focus on the exposure part. They really don't emphasize the response prevention piece. And that leads to kind of suboptimal outcomes because both are really, really critical. So if I go back to this cycle that we talked about earlier, what we're trying to do with treatment is break this cycle. And so with exposure, what we're doing is exposure to the triggers and these upsetting thoughts so that we start to break the links between them and we start to not have the same anxiety responses in response to these triggers and obsessions. And with response prevention, we're trying to break this link between when I engage in compulsions or avoidance, I get this relief, right? And so we're really trying to break the cycle and change the way this functions in people's lives, which is very different than how kind of a more non-specific approach to anxiety management might be. So folks who don't have maybe OCD training might very, with good intentions, coach people on using like relaxation skills or distress tolerance skills or kind of other coping skills to manage these feelings of anxiety. But what you can probably start to see is that a lot of those essentially just function as compulsions or avoidance that lead to temporary relief, but don't actually help the person break the cycle in a more significant way. And so we don't do really any teaching of those skills in this treatment. Instead, what we do is we lean into the fear, we lean into facing the things that are contributing to the problem, and then we really help folks block these behaviors. We're going to talk a lot more about what that looks like. So ERP was initially based on this concept of habituation, which is this idea that when the nervous system is exposed to something over and over again, it stops responding with the same level of reaction. And you can think about this with lots of different body systems. So if you think about, I once moved into an apartment that was by in the flight path of an airport. And when I first moved in, every single plane I felt was like the loudest noise I'd ever heard. And within 6 months, I kind of barely noticed the airplanes, right? Or if you've ever lived on a busy street with a lot of traffic, you might notice those cars a lot more when you first move in, and it kind of fades out over time. Likewise, if you get in a swimming pool, that's kind of a cool temperature. If you stay in for 20 minutes, it feels very different to you than it does when you first get in. Like our nervous systems adjust to things around us all the time. And the same principle applies to fear. When we are exposed to something that we're fearful of repeatedly, our nervous system actually stops responding with the same level and intensity of fear that we have felt before. But that only works if we're not trying to escape or do something to make ourselves feel safer. So let's take the swimming pool example. If you got in the pool and you felt really cold and you got back out, when you got back in again, it would feel just as cold again, right? You have to stay in the pool for it to actually work. And the same thing is true with our fear. We actually have to stay with our fear to see these changes. And so what we'll describe to patients, if we have like time and anxiety here on the side, is that if you stay with an exposure or stay with an experience, your anxiety will come up, but at some point it's going to peak on its own and the nervous system regulates itself. Like anxiety always comes back down. It doesn't go on and escalate forever. And then if you confront that same trigger multiple times, over the course of, treatment, what you're going to see is those peaks just don't get so high. The time to get back down to kind of a baseline is also shorter. And we really see these like reductions in fear over time. That's kind of the core concept of exposure therapy. I mentioned this, I scooped myself here, but I mentioned this a little bit earlier, but we also have these amazing neuroimaging studies, fMRI studies, that offer really compelling data that behavior therapy actually leads to brain changes. So what we see is when we do fMRIs with people with OCD, before they do ERP treatment, and then after they do ERP treatment, we actually see without medication on board, changes in the way those brain structures that we talked about earlier function just from doing behavior therapy, which is something I think most of us know is that therapy can change the way the brain works. Like I think we all intuitively know that. But this is really great data that kind of helps us see that. They have parallel data that shows when people do just medication treatment, so medication alone, no therapy, you see the same changes. So interestingly, both medication and therapy are changing the same parts of the brain, just in different ways, but we see parallel data for those two approaches. A really critical, and I always educate clients about this because it makes them very hopeful that what we're going to do can actually change these things. What is important to emphasize, ERP is not a cure. So as you all know, we don't really have cures for most, if not all, mental health conditions. But so if people do ERP, but then start ritualizing again or start avoiding again, then that brain circuitry is going to move back, more toward the OCD side of things. But if they can maintain kind of that approach of doing exposure and maintain those gains, then we're going to see the brain kind of functioning more like a non-OCD brain. So it's more like a slider, as opposed to like a factory reset switch where suddenly you no longer have a predisposition to have an OCD wired brain. So how do we pitch this to clients, right? Like we have this great tool, but basically what we're telling people is we're going to do all the stuff that really freaks you out and we're going to do it a bunch, right? Like why would anybody do this treatment? Like some clients get it and they're on board and they're ready to go, but others are like, okay, they need a little more convincing. So I usually tell people that ERP is hard. There's no doubt about it. We're going to be doing hard stuff. But honestly, your life is already hard. You're anxious all the time. You're stuck all the time. You might be panicking much of the time. This is not going to be harder than living with the OCD that you already live with. I also emphasize this is a super collaborative approach. So we're always going to discuss and design exposures together. You're never going to be asked to do anything you don't want to. I'm never going to surprise you and say like, surprise, today we're doing this super hard thing. Like we're going to choose things together, we're going to design them together, and we're going to do it at the pace that you are able to tolerate. Some clients go very quickly. Once they get it, they power through the treatment. Others need to go really slowly. We're going to totally adjust that to what they need. My role is to coach you in fighting back against your OCD and teach you essentially how to become your own OCD therapist. We're going to take that at whatever pace is going to work for you. And then I'm also, like I said, summarize the data, talking about how the treatment works, how it changes the brain, like, give them a compelling rationale for why we're going to do that. And then in thinking about the phases of treatment, phase 1 is going to be all the assessment that we talked about. Phase 2 is where we're going to do something called create an exposure hierarchy, which we'll explain in a minute. Phase 3, we're actually going to implement the treatment. And then toward the end, we're going to talk about how to maintain your gains. So we talked a lot about assessment already, so I'm just going to put this up here real quickly. We're going to do the diagnostic assessment, self-monitoring data like we talked about, psychoeducation about all the things that I just talked about. And then if we need to, we'll work on motivational enhancement to really get that buy-in. You really don't ever start exposure therapy until a client is on board. Otherwise, it's going to backfire and going to be a mess. So if that takes months, it takes months. If it takes 2 weeks, it takes 2 weeks, but we're going to take as long as we take, use things like motivational interviewing, other strategies to get folks ready. Okay, so then how do we build the roadmap for the treatment? So we're going to take all that data that the client gathered as part of their self-monitoring for several weeks in treatment to start to identify what are the things that tend to trigger your OCD recurrently, and what are the kind of OCD thoughts and fears that you have. And those are going to build the basis of what we call an exposure hierarchy, which is essentially a just fancy name for a list of things that are triggering for you. Then we're going to have the client assign distress ratings to all the items, so we know which ones are kind of lower level anxiety for you, which ones are kind of higher level anxiety for you. And let's say a client has multiple subtypes. So let's say they have contamination concerns, but they also have sexual obsessions as well. We're going to actually make separate hierarchies for those types of thoughts because they're really different, and we're just going to work on them one at a time. And sometimes the act of making a hierarchy is an exposure for clients because they actually have to talk about all the things that are triggering for them. So we're going to take it nice and slow. I'll just give you some just kind of examples of what parts of an exposure hierarchy might look like. So for someone with contamination concerns, low level might be like shaking somebody's hand, picking something up off the floor, and then usually things like trash cans or door handles, bathroom door handles are high. Bathrooms in general are usually among the highest kinds of triggers, particularly public restrooms, things like that. So this might be kind of a rank ordered list of triggers that somebody might have. Let's say somebody has harm obsessions about harming their loved ones. So things like words could be very triggering for them. Watching content about, serial killers or murderers could be really triggering for them. But often like using sharp implements around people you love could be really triggering because there's a fear that when I'm using the scissors or a knife, like harm my loved one. all the way up to actually imagining, creating, like causing that harm, right? So these would be kind of examples of things we might do with somebody around harm obsessions. So we're going to encourage clients to put all the relevant triggers on the hierarchy, even if they're not sure if they're willing to do them all. We want to get the lay of the land, and then we'll decide kind of with them what they're willing to do and not willing to do. But we are going to explain that treatment's going to work better if they're willing to do all of it. If they don't do all of it, they're leaving themselves kind of vulnerable to not fully extinguishing the fear. I think about it like if you put out 80% of a fire, it's better, but the fire could still reignite and you could have a bonfire again. And so I kind of explain that to clients. Like we'd like to put the fire out completely, not just put it out like 80 or 90% and leave you vulnerable to the sparks kind of coming back here. And it's really going to be the roadmap for the whole treatment. So we want to spend enough time on it that we get it, pretty good, because this is really going to be our treatment plan. And some clients can, make a hierarchy in one session. Not uncommon for it to take several sessions to put that together. And then once we have that together, we're kind of ready to get started with doing exposure. And so the majority of the treatment's really going to be spent actually doing exposure and response prevention. And that, in terms of how long we do that, it depends on how many items are on the hierarchy and how quickly clients are willing to progress through it. Whenever we can, we always want to do exposures with clients first together in sessions. This is a very active treatment. So we're doing exposure together. And then we're going to have clients do exposures also outside of treatment for homework. But doing it in session is really very important. And as I mentioned, this is very much a doing treatment. So it's not really a talking treatment. I mean, obviously we're talking, but the mechanism of what we're going to do is we're going to actually go do the things that make you anxious. And it can be really tempting as therapists to kind of want to dive into interpreting the meaning of people's specific obsessions or fears, because that's a big part of what we do in our field and in our work, is try to understand and make meaning of things. This frequently backfires for OCD for several reasons. There's actually not any evidence that trying to do that is helpful, and it can actually make OCD worse. And one of the ways it can make OCD worse is, by definition, people with OCD are taking their thoughts way too seriously. So, most of us have intrusive thoughts all the time. Like for those of you who lived in Seattle for a while, there used to be a raised highway right on the edge of downtown that ran through the water side of downtown. And I would drive that into work every day because I work in downtown. And I would sometimes have the thought like, oh my God, what would happen if I yanked the wheel, went flying off this thing into, some building in downtown? Or, sometimes, if you're flying in an airplane and you have the thought like, oh, what if the plane crashed today? We all have intrusive thoughts that are kind of random, but most of us then have the thought, and then the next thought is like, oh, well, that's random. And then we kind of just move on with the rest of our day. Well, for folks with OCD, when they have these intrusive thoughts, they're not able to separate from them or just see that like, well, that's just a random thought. It doesn't actually mean anything. They ascribe a great deal of meaning to the fact that that thought is happening, which is why they then get so anxious and it feels so real to them, like they have to do something. So in therapy, if we spend a lot of time trying to interpret the meaning of their thoughts, it can actually reinforce the idea that these thoughts are important or meaningful, and can actually kind of strengthen that OCD response, which we really don't want to do. So we kind of want to ignore the content because, like I talked about earlier, the content isn't actually what's so important. It's helping people break out of this cycle that's important. And we want to focus on how to do that. And so when we would attend to the content is to help people design an effective exposure, right? But we're not going to spend a lot of time talking about the meaning or why you're having these thoughts. Like the reason you're having these thoughts is because you have a biological predisposition to OCD. Your brain is functioning in a slightly different way with these different structures. And then you've been avoiding and engaging in compulsions, and that's made it stronger. Like that's the why. There's not like a deeper why to go for there. And so there's a couple different ways that we do exposure. The first is called in vivo. So that's just exposure to different kinds of situations, people, objects, activities. Another is called imaginal exposure. And so when we can't recreate a specific situation, we'll write out what's called an imaginal exposure script, where we describe the situation and we have the person either read it or listen to it. We'll do that for things that just can't be practically replicated, or when it's not appropriate to do that. So for example, if somebody has intrusive thoughts about stabbing their loved ones, We're obviously not going to have them stab their loved ones. That's not what exposure therapy is. So we're going to have them write out the script of whatever's already in their head. We're not going to put anything in there that's not there already. But if they have kind of a little movie playing in their head every time they're chopping vegetables at home that they might take the knife and go stab their child, we're going to have them write that out. And then we're going to do exposure to that script of what's happening in your imagination. And there's kind of two ways to do that. One is writing a script as if the bad outcome will definitely happen, or the other is that it could happen. So more of kind of an uncertainty angle. And one of those typically resonates more with a specific client about what would be more anxiety provoking to them, like it will happen, or maybe it will happen. And we'll kind of orient clients to that and then pick whichever one is more anxiety provoking for them. Fears of uncertainty or uncertainty about what could happen are a big part of OCD often. And so oftentimes it's this more uncertainty route, like I don't know if I'm a pedophile or not, or I don't know if I could snap and stab my loved one or not, is often actually the more difficult thing for them to consider. Just give you an example of what this might look like. So for religious obsessions, a script might look like, if I have an impure thought in church, this means that I'm a sinful person and God will be upset with me and I will go to hell. Spending eternity in hell will be terrible, as I'll be separated from my loved ones who will be in heaven and I will suffer immensely forever. I would have generated this with the client based on the thoughts that they're already having. So these would be the thoughts that they're kind of having as they go about their life. We're just sort of putting it together in a script that they would then listen to repeatedly. If I was going to change this to more of an uncertainty route, I would insert this language that you can see here in green that is more of an uncertainty bent to it. So if I have an impure thought in church, this might mean that I'm a sinful person and that God might be upset with me and I could go to hell. If I spent eternity in hell, that would be terrible, as I would be separated from my loved ones and who would be in heaven and I would suffer immensely. Subtle differences, but there is a difference in how that can register for people's brains and their fear. And that's kind of an important thing to check out. In terms of getting the most out of exposure, eventually we want to combine doing things in real life with imaginal exposure. So starting out, we kind of do them separately because it's usually too intense to do them together. As treatment progresses, we're going to merge those two forms of things together because that's actually what's happening in people's daily lives anyway. So when somebody encounters a trigger out in the world, they're also then having obsessive thoughts in their mind and fearful images or scenarios in their mind. So the real world trigger and the mental stuff is all happening together. And so we need to create exposures that combine both of those pieces to be most helpful to them. So as an example, if somebody had sexual obsessions about being a pedophile, or we might have them do an in vivo exposure of sitting on a park bench at a playground for 30 minutes just while kids are playing nearby, because that alone will make them anxious. Then separately at home, for a different exposure, we might have them listen to a script about possibly being a pedophile. And that would be based on their own thoughts. We would put together a script based on that. Eventually, I'm going to want that client to sit on the park bench at the playground for 30 minutes with kids around them, while also listening to the script about the fact that it's possible that they are a pedophile. And the combination of those two things is what's probably going to end up being the most helpful for them, because it most closely approximates what's happening in their daily life anyways. So that's the exposure half of the treatment. I will save some time for questions at the end, but I'm going to power through this for another 10 minutes or so. The flip side is, okay, what do we do with the response prevention? So how do we help people block rituals or avoidance behaviors? There's two ways to do this. The first is called full response prevention, where we help people, or people agree to eliminate a ritual completely. So I'm willing to stop washing my hands in this scenario completely. I'm willing to stop checking in this scenario completely. If folks are willing to do this, there's actually data that the treatment, you get better outcomes, but not surprisingly, very hard for people to do. Not everyone is able to do that. So with most clients, we do something that's called partial response prevention, where we work on decreasing a ritual kind of over a period of time, or phasing out a ritual over a period of time. It does make the treatment more tolerable. It also takes longer. And our eventual goal is to cut that ritual out altogether. But oftentimes people need that phase out. And part of how we do that response prevention is, let's say I do something 10 times. Maybe I work on decreasing the amount, maybe I do something for 30 minutes. Maybe I work on decreasing the amount of time I spend doing that. Maybe 20 minutes, then 10 minutes, then 5 minutes, etc. Or if I do something 30 times, let's cut it to 20, 10, 5, etc. If I can't do that, can you delay doing the ritual for a period of time? So if I normally would wash my hands immediately after touching X, can you wait 5 minutes? Can you wait 30 minutes? Can you wait an hour? That kind of thing, to where you build the capacity to sit with that fear while you're delaying the ritual. Or lastly, can you change the ritual in some way? Can you do it differently, slow it up, speed it down? Anything that's just like not exactly how OCD wants you to do it. With all of these approaches, we're just kind of pushing back on the rules that OCD wants people to follow, to give them more flexibility. So as an example, if I have a checking compulsion, I kind of just said this, but I could decrease the time, I could delay it, or I could change the ritual in some kind of way. These are all strategies we'll use if people just can't stop, checking altogether right away. So in terms of the first exposure, this is really important how you start. So you want to select something that's kind of lower. Ideally, you want this to be like a slam dunk, like something the client can definitely do, so that they start exposure feeling, efficacious, right? So it's better to be too easy than to start too hard. You're going to be behaviorally defined. This is exactly what we're going to do, and also what you're not going to do in terms of like the rituals or avoidance behaviors. This is very collaborative. So the client and I are going to design this together. We're going to talk about how it's linked to their goals of being less anxious, of kind of breaking out of this OCD cycle. And our goal over time is to teach clients how to design exposures, for themselves. Always want to do the first exposure together with the therapist, so the therapist is there to coach and sort of see what is happening. And we also want to set the expectation that, like, as you stick with this exposure, your anxiety might come down, but it also might not. Treatment is effective either way, but people usually see reductions in their anxiety when they do this, sometimes fairly quickly, with that particular exposure that you're working on, but sometimes they have to do it multiple times before they see that change. So an exposure might be for hit and run OCD. We're going to drive for 45 minutes on surface streets in the right-hand lane. I picked the right-hand lane because that's closer to where pedestrians are usually, so it's usually harder for people. And then what we're not going to do, we're not going to drive around the block to check to see if you hit someone. We're going to limit how much you're looking in your mirrors behind you to see if you hit someone. In this case, I'd be in the car with them, so they're not going to ask me whether they hit anybody. And then you're not going to check the news later about whether there were any hit and runs today. So really behaviorally specific, what we're going to do, what we're not going to do. And then equally important, homework. So there's actually a lot of research data that the more homework people complete in ERP, the better their treatment outcomes. And it makes sense, because if they're only doing exposure with a therapist like once a week for an hour, you're not going to get anywhere near as benefit as if you're also repeating that exposure throughout the week. So as soon as they're willing, we're also going to start assigning homework assignments that people are doing exposures on their own, usually replicating something we did in session or building off it in some way. And ideally, clients will keep a log of their exposure practice so we can see how that's going. How hard was it? We can also kind of assess, like, does it seem to be working? Do we see their distress ratings kind of getting lower over time? Sometimes that doesn't happen. Usually it does. But we kind of want to track how that's going. And when a particular trigger, we've done enough exposure that the distress around it has dropped to pretty low, or the person's bored, or they feel like they can move on, then we move to the next item on the hierarchy and we slowly work our way up in that way. It's kind of do's and don'ts of exposure. Some things we do want to do, really validate how distressing and hard this is, really encourage and cheerlead the client as they do it, remind them of their goals if their motivation is kind of wavering, occasionally asking kind of what their distress level is, so we're tracking that, kind of looking for whether they might be ritualizing in different ways, really helping them stay focused. People can want to kind of check out or avoid, or kind of get away from the exposure, which makes sense. We want to help them stay on track. Want to help them learn something new, hopefully, by sticking with it instead of avoiding. And if they need short breaks, they can do that, but then we're going to come back, to the exposure and stick with it. And if exposure kind of goes badly, and what I mean by goes badly was, like, maybe we picked something that was too hard, or we didn't really think through the steps carefully enough, and it just kind of doesn't go as we planned. As a therapist, I always take responsibility for that. It's my job to help guide you. We kind of missed the mark there. Let's kind of back up and try this again. We don't want to do is provide a lot of reassurance. We don't want to be telling clients the whole time, like, you're safe, this is okay, you're safe. Like, that's just kind of colluding with the anxiety. We don't want to talk a lot, because that actually distracts people from the exposure. We don't want to cut exposures short because we're worried ourselves or anxious ourselves about is the client okay? Or, oh my gosh, looks like they're having a panic attack. I need to cut this out. We also don't want to coach on like distress tolerance skills in the middle of an exposure, usually, because that's going to actually undercut how effective it is. And so when exposure is not working, it could be like we're not doing enough. The dose is too small. They need to do it longer or more repetitions. Maybe they're not paying attention to the trigger enough. They're distracting themselves, or they're kind of not focusing. Maybe they're doing some kind of ritualizing. Somebody mentioned mental ritualizing earlier, and this is one that can come up. People might be doing rituals in their heads that maybe we can't see, so we're not picking up on as much. And so that could be getting in the way. Or maybe we just haven't quite figured out the right trigger or the right fear yet, and we need to back up and do some more assessment to help figure that out. And then in terms on kind of how we deliver it, so there's actually data that therapist-assisted exposure is actually more effective than only sending people to do exposure for homework. So really important, like I said, that we do it with people. If we look at in vivo versus combining in vivo and imaginal, they actually both work very well, but you do see a slightly bigger effect size for when you do combine them, but it's not statistically different. And we do see that when people can do full response prevention, they do better than partial response prevention. Although what I'll say with all these findings is all of it's working really well. It's just some things work even better. And then lastly, we're going to do kind of relapse prevention planning. So what are the things that could come up when we're done with we're done with treatment that could trigger your OCD? How will you know when it's time to restart exposures, either with a therapist or on your own? We might schedule some booster sessions, talk about when to come back into formal treatment. But we want to present this idea of making ERP a lifestyle so that people really lean into discomfort in a broad-based way in their lives as a way to keep up and maintain their gains. And really quickly, I just want to mention that there are different levels of care for OCD that are needed. Many folks with mild to moderate OCD do just fine in standard outpatient, where we're meeting usually once a week, maybe twice a week, but usually once. Minimum number of sessions, 20, usually 15 to 20, although many folks need more. But some folks with more severe symptoms actually need to go to an intensive program, either intensive outpatient, where they're going 3 to 5 days a week, multiple hours a day, all the way up to residential level of care. And I've been humbled multiple times in my career where I've been trying to treat people on an outpatient basis because I'm an optimist and I think we'll be able to do it. And then we actually really end up having to move folks to residential, and then we see really substantial gains. So I'll talk about where some of those programs are. So some resources if you're interested in learning more. The IOCDF is probably the best organization in the world for information and training about OCD. They also have a huge list of all the IOP and residential treatment programs that are available. So if you ever needed to refer someone to that, they're a great place to look. They also do a 3-day intensive training that would be a much expanded version of what we just did. That's outstanding. I've done it. I also help lead them. It's probably the best kind of OCD training we can get as clinicians if you want to learn more. Also, for those of you here in the Seattle area, there isn't a free OCD and hoarding support group, ocdseattle.org. It's peer facilitated. It's been around for like 30 years. It's available for folks with OCD, as well as hoarding, as well as friends and family of anyone with OCD. So parents, spouses, etc. They can go even if the person with OCD doesn't want to go. They meet monthly on the 3rd Saturday of the month at Swedish Hospital on First Hill, and some months they're also online. Outstanding resource. Usually one of the therapists from our center is there giving some kind of talk or kind of there to help out, but it is a peer facilitated group, but it's free, which is really rare to find. I'm going to send you all these slides, so you don't need to write all this down, but a number of books I would recommend that are kind of outstanding, both for clinicians as well as clients. Also parallel books for kids and teens, as well as family members and parents as well. And then just to know, these are the residential programs that are available for OCD. The only one that takes kids and teens is the one in Wisconsin. But these would be the 3 main kind of places if folks really have severe OCD and kind of need that level of care. All right, I have talked a lot. I am going to stop sharing, and we have about 10 minutes for questions if folks have them. There's also some more information in the slides that we won't get to, but I'll send you the slides, and there's some more you can take a look at. Yes, Erin.
So first off, this was so helpful. Thank you so much for
You're welcome.
delivering this in such an easy to digest way. What I'm curious about is the relationship between, or how these two things interact, like between trauma and OCD.
Yeah.
And I guess similar to that, or is I have a client who had a lot of trauma from being a part of the troubled teen industry. And so I'm curious if you've seen much of like how that interacts with OCD as well.
Yeah. So there's, sorry, I have like 6 thoughts at one time. Let me pick one of them and talk about one of them. Most folks that have trauma will not develop OCD symptoms. So in that sense, like they're very separate disorders. There are though, and there are definite, there's literature on this too, places where OCD and trauma intersect and are very intertwined. Sometimes what that can look like is somebody has had, you would probably have already had a predisposition to OCD, right? So the OCD wouldn't kind of just develop because of the trauma, but let's say you had that. Let's say you also had some trauma. Sometimes the rituals and what folks are focused on are the trauma cues or the trauma related kind of events. So you could see people who, let's say somebody had had some kind of sexual abuse or other kind of inappropriate abuse. You can see that their contamination, OCD, can take on the flavor of like, I feel contaminated from these events that I had. And so I'm doing rituals that last, for years around like decontaminating myself from that event that I experienced would be an example. So you can see the rituals of the OCD get really intertwined with the trauma. What we have to do there really carefully is kind of figure out like, what do we need to treat first? Sometimes we actually need to do the trauma work first because we're not going to make any headway with ERP if we're immediately triggering trauma memories like every time we start to change the ritual pattern. And sometimes what we have to do is kind of actually like carefully move between the two treatments kind of as we move along. The good news is like if you're doing an exposure-based treatment for PTSD, which is also common, the elements of what we're doing are very similar. We're just kind of thinking about them like how they work in tandem in a different way. But I do think sometimes we really have to figure out how to sequence those treatments and how they kind of interplay with each other. I don't know if that answers your question enough, but that's how we think about it. Okay. Kelly, I think you might be next.
Thank you. Yeah, I had the same question about trauma and OCD. And I'm also wondering, kind of in a related way, this is kind of a bunch of thoughts together, but wondering about PTSD and OCD, which you kind of already talked about. And then also like, what have you seen since COVID around OCD and contamination, and even like,
yeah.
Yeah.
Major impacts. COVID had a major impact on many people with OCD. Interestingly, two impacts. Does everyone have a hard stop at 12? Some people. Okay. If you can stay, feel free to stay. I have a few minutes after, but I'll try. 2 things happen. A subset of people with OCD had the response, I was built for this. I was built for a pandemic. I already lived my life in a, like, I'm prepared for this. And they felt a huge degree of validation that huge parts of the world were suddenly following the kinds of protocols that they've been following for years. So a lot of people were like, I'm fine. I already lived this way anyways. This is not as big of an impact on me as you would expect. So that was interesting. I didn't really see that coming. Other folks, their contamination or illness worries like just went through the roof. And what we see there is that as other people without OCD were able to phase out things like masking or social distancing or taking more risks, like we have patients that are still as rigid with those rules as most folks were like 2 years ago, where they can't let go of those procedures because it feels too scary and too threatening to them. And so we're now like to the point where many people are moving about their lives in a much more free way than they were, but they're still stuck at home, like looking like they're in quarantine because they can't, the OCD has totally grabbed a hold of those rules and like can't let go. So, and other things happen too, even with other types of OCD, because people were so isolated, they weren't getting opportunities to do exposure to all sorts of the things that create their fears. And so that it kind of facilitated avoidance. And so you had this period of time for a couple of years for other people where their OCD got worse because they actually couldn't go out into the world and do the exposures that they needed to do to get better. So we saw like lots of different ways that COVID has kind of impacted OCD. I did want to say a real quick thing more about family members though, since Amisha, you'd asked about that. In ERP, what we would do if there was parents or spouses that were like involved in ritualizing as part of the treatment they would be clued in when we would get to the item on the hierarchy that related to them, and they would be like brought into the session to talk about, we're now ready to tackle this behavior. And so here's what we want you to do or stop doing, you know, as part of that. But we want them to wait until we're ready, because some parents and other folks, once they learn like, oh shoot, I'm accommodating the OCD, I'm actually making it worse, they want to just like stop and pull out of all ritualizing, which is kind of going to be a disaster for the client. So we want to educate them like, we are going to help you, you are going to get some relief. We need to wait until we're at that point in the treatment. And then when they are, you're going to have specific homework, you know, essentially instructions as well, so that you stop doing certain things as the client, you know, starts to take them on. And sometimes we actually need to refer those family members to their own therapist to get even more support on like what it's like to live with folks that have really severe OCD and things like that.
Quick question. I know that just to fall in line with this, but so would that be like, would you say that in front of the client, like if a spouse were to come in? Oh, okay.
Yeah. Everyone is fully aware of what we're doing.
Oh, okay.
Yeah, for sure. Yeah.
Thank you so much. I really appreciate it.
Absolutely. Marcus and Savannah, do both of you have to go right at the hour? Great. Okay, Marcus, go ahead.
Great. And for everyone who does have to go, just again, email Alyssa for CEU credit stuff. So for some clients I have who are on the autism spectrum, there's some overlap in symptoms like rigidity and repetitive thinking. Not probably to the level of an OCD diagnosis. But I'm curious if there's any kind of neurological overlaps in how their brains may be working.
Yeah, so you do see higher rates of OCD in folks on the spectrum than in the general population. So there's definitely some connection there, kind of biologically. What OCD can present, well, two things can happen. Folks on the autism spectrum can have those behaviors that you just described, but they're less fear-based and they're more like rule-based.
Yeah.
So we don't always see like fear being the driver. And so there's a question of like, well, is exposure the right approach to that or not? It might be like helping them change the rule. And then suddenly sometimes they're able to like change their behavior quicker than we might think, because it's not so much about fear. It's more about a rule that if the rule gets replaced with a more functional rule, they're able to kind of shift those thoughts. The other thing is that when folks on the spectrum also have OCD, their presentation often is quite different. Like because they also have a harder time describing their internal experiences than folks who aren't on the spectrum, it can be really hard to do assessment because they can't always articulate a lot of their internal experience as fluidly or easily as other folks can. And then their presentation of anxiety is often very different too. Like they don't always necessarily look anxious in the same ways that folks who aren't on the spectrum look. And so when you're in session doing exposures, it can be harder to gauge kind of their anxiety level or for them to gauge their anxiety level. And then sometimes exposure just goes differently. I mean, sometimes it's harder, but sometimes it's faster. So like I said, sometimes if someone has contamination OCD and they kind of have a rule that like you're supposed to do X, if you give them some information and like an alternative rule that they are like, oh, okay, that makes sense, they literally just stop like all of the behavior that was related to that in a way that folks that aren't on the spectrum, like you would almost never see that. So you can see these like sudden changes sometimes, and other times it can actually just be like a really laborious process just because of all the other kind of barriers that I just mentioned. But
yeah. Thank you. That's super helpful.
Yeah. And Savannah.
Well, I was definitely curious about what Marcus just asked, so that was really helpful. I was also wondering about the distinction between OCD and social anxiety, just recognizing that they're both anxiety disorders. And I think what I see a lot of the times with my clients who struggle with social anxiety is there's sort of like a replaying and a fixation on social events and kind of a really concentrated, distressing, picking apart of every element of an interaction that kind of looks in certain ways, maybe like a compulsion or a fixation, but it's kind of hard sometimes for me to parse that out. And I wondered what your thoughts were about that.
Yeah, so that's a great question because you can see compulsive behaviors actually in any anxiety disorder as one of the things that people do to make themselves feel more comfortable. And so, yeah, sometimes this can look like really compulsive, but doesn't necessarily mean that the individual has OCD. specifically. Like I'd say if the main fear is like this fear of negative evaluation from other people, and that, you know, I'm worried about how I'm coming across, like social anxiety is probably the right diagnosis. But you'd be kind of doing ERP would be the same concept, which is we're going to have you work on approaching these social situations that trigger those concerns for you. And then we're going to really work on trying to figure out how do we interrupt this kind of ruminative kind of replaying process that happens afterward, so that you have the chance to kind of learn something different, you know, from this experience. We don't have a lot of time to talk about it today, but blocking mental events is obviously harder than blocking overt behavioral events. But there are things you can have people do to intentionally distract themselves cognitively, like in those windows after they've done something where they want to kind of replay or ritualize. One thing you can do is have them have an exposure script, like we talked about, that they listen to repeatedly in that time frame, which makes it harder to mentally review something while you're listening to or reading something else. Another thing you can have people do is do some sort of mental task that's hard, like count backwards from 1,000 by 7 during the time period that they would normally be like mentally reviewing, because it's like literally impossible to do both of those things at the same time. The other thing you can do is something that we call spoiling. So if the person is trying to like pick apart, like, did I kind of blow it in this example, or I think I did okay, or I'm not quite sure what happened. If they're trying to reassure themselves that they're okay, what you can do is reintroduce the uncertainty. Like, I actually don't know what anybody else thinks. It's literally impossible for me to know. Like, I might think this went well, I might think this went badly, but I literally cannot know. And I kind of have to sit with the fact that I can't know, and kind of sitting with that uncertainty can be helpful. But first, they have to buy into the idea that like that reviewing is not serving them. Because at first they usually think it is.
Yeah.
Because like if I can parse out what I did right or wrong, then I can either prevent that from happening in the future, or I can understand what's happening here. Like, so the first part is getting the buy-in that it's actually not useful to do this. This is causing you more distress. And you actually can't know what anybody else thinks anyways, unless they tell you. And then if they're willing to try some of these other ways to disrupt that behavior.
Thank you. That's really helpful.
Yeah. You bet. Any other questions? Okay. Great. Well, thank you, everyone. Marcus, I'm going to send you a PDF of the slides. So you
Great.
can send that out to everyone who's here, but also anybody else who wants them. And then I'll get you the recording hopefully by Monday.
That's fantastic. Really, thank you so much. I think it's make a topic that's pretty intimidating for a lot of therapists, at least to have a pretty strong framework that has a lot of kind of intuitively makes a lot of sense. So I really appreciate your time and expertise and bringing that to us.
Great. You're welcome. Thank you, everybody.
All right. Thanks,
Bye.
everyone. Bye-bye.
Bye-bye.